Transmission, absorption, and scatter. Transmission and absorption are good. We want those to happen because that's how we see differences in the body. Scatter is bad. We don't want scatter because scatter degrades the quality of our image. It makes the image look foggy. It makes it look more gray. It's harder to make out details. And so the thicker the body part, the more scatter we have. Abdomen is a relatively thick body part. Therefore, we want to make sure to use a grid with the abdomen. And so this is our basic KUB. Right? Unfortunately, this person did not catch the pubic symphysis, so we do want to make sure to get that, but they do have the diaphragm up top, which is good.
Did they digitally collimate that?
So that is tough to tell.
They used a digital marker.
They did use a digital marker, that's true.
Sir, which is the diaphragm up there? The top one or the bottom one, sir?
What do you mean top
Oh,
one?
it's I see. Okay.
What did you say your average KVP mass was?
So on the average patient, I would use something like 75 kVp and 25 mass. Although, since we're in Houston, maybe I would use like 80 kVp and 32 mass. Okay, just say it.
But what are you going to ask us on what would be like the correct?
So I will not ask you something like what's your average mass. That is something for you to keep in your mind as you go to clinic. Because the registry isn't going to ask you like direct exposure factors like that. The reason is because these will change depending on your equipment. More modern equipment is more sensitive to X-rays, so we need lower exposure factors to get the same image. So it's going to vary on a equipment to equipment, location by location basis. So I won't ask you exact numbers, but what you should do is when you go to clinic, make sure you pay attention to what numbers are showing up on that control panel. When you shoot a chest X-ray, check your control panel to see what the KVP is and what the mass is. Not just the MA, but make sure you know what the actual mass is. Some control panels will not show you the mass immediately. They only show you the mass for about 5 seconds after you shoot the X-ray. So once you press the button, before you run in, just glance over at the control panel and see what mass readout did it actually give me. Yes, Jay.
So you wouldn't ask us like if a stenic patient comes in, what KDP would you use and what mass would you use?
Correct, I will not ask that.
Okay, even if you provided the body habitus and
Even if I provided body habitus, I will not ask that. The only time you would see a question like that is in PRE, when I'm asking you to adjust factors.
okay.
I'll give you your initial, I'll ask you to find the final based on some change I need you to make.
Okay. As if I'm sorry.
So what do you mean by with, I didn't understand what you meant by with, how does a grade affect the technical file?
That is gonna be something for another time. That's
So
gonna
what-
be PRE.
But you did say something about the grid this time.
Grid improves the image quality, it reduces scatter.
Grid improves the image quality and reduces scatter.
It improves quality by
Reduce.
reducing scatter.
And-
Scatter reduction is what causes an improvement in quality. Okay. So, first thing we're going to talk about is the apple core sign. If you take a look, right here, right, it looks kind of like an apple core, right? Like someone bit a chunk out of the apple. Do you see that? Okay, over here you see how it looks like this dark part is the apple and someone bit a chunk out of the center. Right, here's your apple and then someone
Big
bit a
bite.
chunk out of the center. Big bites, right? So, what is causing this? Well, the white stuff here is barium. Barium is contrast that we use, that we put into the colon, the large intestine, to visualize it better. And so as you can see, the barium has completely filled up the colon, except for here. The barium did not enter this area. Why not? Constriction. Okay, so the colon suddenly just shrunk here? Okay,
I think there's 2 masses there.
masses. Okay, so like a tumor or a cancer. Melanie? Did you say something? Something probably stuck there. Good. So yes, there is something constricting the colon. So often it's going to be due to a mass, due to a cancer that's around the colon that is squeezing it tight. So, or it could be a mass that's actually growing off the surface of the inside of the colon.
But those would be 2 different cancers, right? If there was one outside the intestinal wall, one inside the intestinal wall.
Would they have different names? That I am not sure about. I do not know if we would change the classification based on if it's inside or outside the wall. It's a good question. But this, if you do see this here, right, this is called your apple core sign. It is a sign of pathology. So what kind of study would you see this in?
DE.
Barium enema, BE.
Fluoroscopy.
Fluoroscopy, good. Right, so barium enema in fluoroscopy, where contrast is placed into the large intestine, into the colon, this would let you see that apple core sign. Now, because we are using contrast for the study, we may need to slightly increase our exposure adjustments, because as you can see, contrast is radio dense, it's radio opaque, right? It blocks X-rays. So we might need to go up on our energies just a little bit in order to penetrate the patient. Any questions? Contrast is, so, sorry. Positive contrast is radio opaque, because we do have negative contrast as well. So positive contrast absorbs X-rays, makes things show up bright or white on the image. But we have negative contrast, which causes X-rays to pass through more easily, and so that shows up black on an image. And who's been in fluoro so far? Cody? All right. So, have you seen upper GI exams done
Yes.
in fluoro? Yes. And so they have the patient drink some barium or some contrast, correct?
Yes, it's a single contrast and a double contrast.
Good. So they have single and double contrast exams. On the double contrast exam, what else do they drink aside from barium?
I believe it was some kind of Alka-Seltzer-like substance. I don't know the specific name. I didn't catch the specific name.
Very good. So it is an Alka-Seltzer-like substance. It's these crystals that if you put water onto them, they begin to fizz, they begin to bubble. And the patient drinks it as it's bubbling. So the barium is positive contrast, right? It is going to show up bright white like this in the patient's stomach. But that Alka-Seltzer fizzy stuff, that is negative contrast. It's going to put air into the stomach because it's bubbling. And so that air is going to show up dark inside the stomach. So now you have this nice delineation of dark versus light in the stomach. Right? So
Yeah,
that's,
because they try and tell them not to burp, you
Mhm.
know, after they drink that, because I guess that's because of the air thing. They don't want them to lose air by burping.
correct. Yeah, so the patient feels really bloated when that happens, yes. But we need them to keep that air in the stomach. Helps expand the stomach, makes it a lot easier to see what's going on.
That
It gives us that
nice
negative
though.
contrast.
Like a 10 out of 10
But-
burp right there.
Yes.
Positive contrast is radio comes out bright white.
Mhm.
Negative contrast.
Is radiolucent and comes out black. So an apple croissant.
Why is that?
Why what?
Why the apple?
Why isn't the apple? Oh, I'm sorry. Alright, we'll move on then. Okay, ascites. Ascites is just extra fluid in the abdomen. Okay, so it's an abnormal amount of fluid in the intraperitoneal area. So normally the abdomen has fluid inside naturally, right? It helps to coat the organs, it helps to lubricate them. But if there is an excess of fluid, if there's extra fluid, now it's going to kind of like swell up the abdomen. A lot of times you'll see when you go out to do abdomen x-rays on patients, you'll see that their stomachs are kind of swollen like this. But if you press on it, it's like hard. It's almost like rock hard. And that's from all the fluid that's built up inside that abdomen. So you're pushing down and it doesn't really sink in because all that fluid is pushing back against you. So it can be a bit difficult to palpate those types of patients because you can't come in from the front where it's bloated. You have to try to come in towards the back or use some other landmarks instead.
This is an ascites when it's so hard.
Ascites, yes.
Ascites.
So usually requires more than half a liter of fluid to be visible on a radiograph. What causes ascites? It could be cirrhosis of the liver. This is pretty common. Cirrhosis often caused by too much drinking. Yes. And then metastatic disease in the peritoneal cavity. Once again, talking about metastatic disease, we're talking about cancers, malignant cancers. It presents with abdominal distension. So like I said, if you look at the patient, the abdomen looks swollen. And this is seen as general abdominal haziness. So the abdomen looks a lot fuzzier, it looks a lot whiter than you would expect because of all that fluid. So if you look at this picture, it just looks a little bit more white. It looks kind of whited out compared to a normal abdomen. Yes, Shamika.
Question: will we have a class over like knowing the technical factors, or we have to pay attention to all that in clinic and just get the numbers from there?
So your marrows will give you some kind of suggested technical factors. But no, we're not likely to go over specific numbers for every single piece of anatomy. So it is going to be more on you when you go to clinic to pay attention to what they are using out at the clinical site. So make sure you bring your notebook with you. Anytime they do an exam, write down what kind of exam, okay, chest PA, and then take a look at the numbers. All right, 120 kVp and 1.63 mass, right? And you keep doing that for every exam. Okay, lateral chest, 120 kVp and 2.94 mass. And as you do that, and also write down what size the patient is. The patient looks stenic or astenic or hyperstenic. And by doing that, you begin to build this kind of like technique chart in your heads as to, all right, I have this size patient for this kind of anatomy. I've seen this before. What kind of numbers did I use before?
I know in fluoro, we had to write down like how many images we took, how many, like the time they were exposed, and then like the amount of exposure they received. I know they were talking about with the resident when he was taking pictures. I think there's something on the machine where you can have it take like 3 images instead of like 1 or something like that. I wasn't really sure what it meant, but because he was doing it that way, it was exposing them more. And like he had to do it that way basically because the doctor the doctor with him that was not a resident was telling him to do it that way, and he was like, after that exam, he was like, wow, that was like a lot of exposure compared to like normal.
Yes.
And it was just because that one doctor wanted to have like a 3-picture thing and whatever. But anyways, sorry.
Right.
It's kind of off topic.
No, but that's good. That's good to bring up. So yes, we are actually required by law for fluoroscopy exams like fluoro, OR if you're in surgery and you're using the C-arm, or in IR. We need to mark down the fluoro time, how long the X-rays were actually on, because those can range from 15 seconds up to 15 minutes or beyond. And we need to also write down the estimated dose. So we need to have a dose report on all patients that go through fluoro or C-arm imaging. And yes, the more images you take, the higher that dose will be, right? 1 image to 3 image, you would naturally expect 3 images to be 3 times the dose of the 1. Sometimes it's even more, depending on exactly what kind of images you're getting. Because in fluoro, if we could just come back here for a second. In fluoro, the images actually look kind of like this when you're first shooting them. And then you can use a higher power, and then it ends up looking more like this instead. So sometimes using the regular fluoro image is enough. You're just briefly shooting, you're moving around, it's like, oh, that looks like a good image. We'll just save that as is. Sometimes you shoot a good image and like, all right, hold it right here. We're gonna take a detailed shot. And they do a much stronger exposure. And that can also influence how much dose the patient gets. As the technologist, you are the expert. You are the radiation safety expert in the room. Okay? So you need to be proactive, and you should be trying to advocate for your patient if you notice the doctor is doing something that does not seem right for your patient. So, for example, you should be warning the doctor about fluoro time. Doctor, we've already done over 5 minutes of fluoro, right? So I want you to keep that in mind. Okay? Or if you see them exposing unnecessarily, you could maybe tell them, hey, maybe we can try to do this and this instead to lower the number of times we need to make an exposure. Yes, Jay?
And the doctor wouldn't be offended by us like asking? Or
They should
suggesting?
not be. Now, doctors are human. Some of them have egos. Some of them may be offended. But too bad for them, right? Because it is the patient who is at risk.
Would we advocate while the patient's in the room while we're doing the thing? Or like, pull the doctor aside and say, hey, XYZ.
So that depends. Fluoro time, you need to announce.
Okay.
We are required by law to announce fluoro times every 5 minutes to the doctors.
And if the patient, what are you talking about? You know, what?
So in that case, just be diplomatic. Just be
Okay.
We've just been shooting images for over 5 minutes now.
Okay.
Right? But yeah, some things you can maybe wait to put a doctor aside for, but for fluoro time at least you should be announcing it.
Okay. Sorry.
You're okay.
Is there a
Enjoy.
limit for how long the exam should be? Like how much?
So there's not necessarily a limit,
Yes.
but as you work, you'll get an idea of how long an exam is expected to take. And if you, sometimes you'll notice that it might be taking significantly longer. And so make sure you're kind of paying attention to what's going on in the room, so you can get an idea of why the exam is going longer. Maybe it's just the doctor's having a really tough time finding this pathology, so he wants a whole bunch of different angles to look at it, in which case, all right, sure. But maybe the doctor isn't quite sure what he's trying to do, and at that point, you might be able to step in and say, let me try and help you out here. Okay, or maybe you should call your upper level. Okay. But just be polite, just be diplomatic.
I thought it was interesting because there was one time when he didn't take any images, but because of that, Dahlia went and took one of up here of the throat, And because I asked her, I was like, because I thought it was a mistake because there wasn't any images.
Mhm.
And she was like, sometimes they just don't take any. And then she went and took one because she said like it's required that they have at least one image to say that the exam, I guess, was done
Mhm.
or something like
Correct.
that.
Right, as proof of the examination.
Yeah.
Ideally, you could just do a save last image so you wouldn't need to re-expose. So hopefully the doctor would be forward-thinking enough to just let you know, I don't plan on needing any images, but go ahead and just save the last thing we did so we have documentation the exam was done. Okay, so that was ascites. Next up, we have something that's kind of opposite. We have pneumoperitoneum. So once again, we're dealing with the peritoneum. What does pneumo mean? Air, very good. So now we're looking at air rather than fluid in the peritoneal space. So anytime we are dealing with air in the abdomen, how should the beam be positioned? How,
Straight because it rises.
so how should your tube be aimed?
Oh, 90 degree.
90 degrees. 90 degrees, which means
To 20.
horizontal.
Horizontal.
Good, so 90 degrees, horizontal beam. So, what position would the patient be in if you have a horizontal beam?
Right, sir.
Upright.
Upright or
Decubitus.
decubitus? Good. So when we do things for air like this, we want to make sure that we are doing either upright or decubed. So as you can see here, for pneumoperitoneum, we're going to do an acute abdominal series with an upright. If the patient cannot stand or sit upright, what do we do?
Then the
Left down.
decubitus.
Now we go to the decubitus. Very good.
Can we guess on this one where we think the free air is?
Yes, please. Where is the free air?
I think it's on both sides.
It's right there.
Up, right, far right there, and then up to the left, underneath the diaphragm.
All right, so we see air here, and we see air here, correct?
All over the throat.
So, are those both signs of pneumoperitoneum?
No, this is gas, I think. And
So,
that.
air
one
is
of the-
gas.
There are all these black shadows, I was
That's
told
the
that it's
colon.
gas.
So, if we take a look down here, right, at these black shadows here,
They probably gas, is that so?
this black shadow is the large intestine. So this down here is the large intestine.
And the one on the top is the pneumothorax.
But under here,
Peritoneum.
not thorax.
Peritoneum.
Pneumo.
Okay, so not pneumothorax, right? We're not in the thorax anymore. So we have air under the diaphragm here, and we have air under the diaphragm here. However, there is a difference between these two sides. What anatomy do you have here on the patient's right?
Liver.
Liver.
Liver, great. What anatomy do you have here on the patient's left?
Stomach.
Stomach. Good. Does the liver naturally have air in it? It does not. So if you do see any air under the diaphragm, so the diaphragm is this white line here. If we see any air under the diaphragm, then yes, that is a sign of pneumoperitoneum. Does the stomach naturally have air in it?
Yes.
It does. So when you see air on this side, it's hard to tell if this is this gastric bubble, air from the stomach, or if this is actually pneumoperitoneum. Sometimes they'll even overlap, so you can't really see it. So if we want to check for pneumoperitoneum, we want to kind of avoid looking on the left side, because if you see air, you can't guarantee that it's pneumoperitoneum versus just air in the stomach. You want to look here on the left to look for that right there by the liver. Which is why, if you need to do a decubitus on a patient for pneumoperitoneum, which decube are you going to do?
Left lateral.
Good, left lateral decubitus. You put the stomach down, you put the liver up. Because if you see air up there by the liver, you know it's free air. You know it's not coming from the stomach.
Does it hurt the patient when we put them in a decubitus because the air's got to travel now?
It shouldn't hurt them any more than they are already hurting.
Okay.
Right, and whatever discomfort they have from laying on their side.
Right.
But the air traveling should not cause issues.
Okay.
So why would there be air in the peritoneal cavity? Well, maybe there's a perforation, okay, or maybe, right, so could be a perforation in an organ or just a perforation in the abdominal wall. This is a serious condition, so the patient would require surgery to correct this.
What kind of therapy is that? I'm just curious.
That's also a good question.
I feel like they would have to isolate the area so that they can know what they're cutting and fixing, right? So
So the thing is, the peritoneum kind of covers basically the entire abdomen, right? It's
Right.
this giant sheet of tissue. So it's not like, oh, the air is here, so it's always going to be here, right? It just depends on how the patient is laying. So how exactly do they treat this? That's a good question. I've never sat in a case where they did that. So that's definitely something I would like to look up.
Get ready to-
So, I would think that they would find where the air is coming from first, right? So like, let's say it was in the large intestine. They do that exam, then they go in and, you know, stitch it up, glue it up, whatever they do.
Mhm.
But if it was in the stomach, would that be a different exam? So it's like a gastric perforation or whatever?
Honestly, that I do not know. That's something I would have to look
Okay.
up. So.
So I have a question.
Yes, go ahead, Shaheen.
So when you said that because this is the liver and this doesn't have the air, and now you say perforation in the organ, so which organ would we be referring to on the left side and
I mean, it
on
could be
the
a perforation of the intestine, it could be a perforation of the stomach.
or
Could be-
stomach is on the right, so this air is showing
Okay.
on the
So, yes, that's true. Stomach's on the right, ear's on the left. But remember, the peritoneum covers the entire abdomen.
oh, I see.
So
that
air
would-
can travel left to right. It has free passage.
That's why we do the decubitus, right? If you turn them over, it'll start to go up.
So next up, we have dynamic or mechanical bowel obstruction. Okay, so this is different from something like ileus, which is non-dynamic, non-mechanical. Mechanical just means that there is something like physically obstructing the bowel. In this case, we may have fibrous adhesions, Crohn's disease, intussusception, or volvulus. Do any of these names look familiar? Did we discuss any of these?
You gave us a page to find them.
Okay, sorry, that's true, I did give you a page with all of these.
Yeah.
Did you discuss any of these with Mr. Donahue?
Last semester we had.
Volvulus.
Volvulus and Crohn's disease.
Fibers?
Intussusception.
All of them, really.
Yeah.
Oh, all of them, okay, great.
I don't know about fibers.
I-
Oh, okay. Well, in that case, let's talk about fibers.
What about torsion? Was that? Oh, that was Wednesday, right?
That are connecting and.
Testes, scrotum, whatever.
Right?
Yeah.
The fibers adhesions?
So fibrous adhesions, basically we have fibrous tissue in the abdomen. If the intestine gets wrapped around the fibrous tissue, so the fibrous tissue kind of like knots around it, right? It can create this constriction around the tube of the intestine. Okay, so fibrous band of tissue causes this blockage. If you take a look here, this is a CT scan of the bowel. You can kind of see here, there's this adhesive band. So it's the soft tissue here that's kind of wrapped itself around the intestine, and now it's constricting it right there. So this creates the look of an air-filled small intestine. This causes the small intestine to look like it's filled with air, and because we have more air in the abdomen, what happens to our exposure factors?
Decrease.
Right, we want to decrease them. Right, more air means the abdomen is now more radiolucent, and so we decrease our exposure factors to match.
So for like most pathology, like if it's more of a liquid problem, like mucus, whatever, you're going to increase your exposures, and then if it's air, anything related to air, it's most likely a decrease.
Very good.
Okay.
So if there's an increase in fluid, increase your factors. If it's a pathology that's an increase in air, then decrease your factors.
The fluid is radio dense.
Good. Fluid is radio dense. It is more radio opaque. Radio opaque. Good. Okay.
Damn, this phone that they got.
Yeah, I'm proud of you. I'm proud of you, Carol. Okay. Crohn's disease, also called regional enteritis. Itis tells you what?
Inflammation.
Inflammation, good. So inflammation of the intestines or the walls of the intestines. And so when this happens, the intestine may form fistulas. So a fistula is a connection where there should not be a connection. And so normally the intestine is just supposed to be this tube like this, right? But with Crohn's disease, occasionally this tube may form a tunnel in between these 2 points which should not exist. Or that tunnel, rather than going in between the intestines, may go from the intestine out into the skin. And so occasionally you have these fistulas which on the surface of a patient, which is basically a hole that leads down into the intestine. You can actually put a tube through the hole and that tube will be inside the intestine. Yes?
What I feel like we kind of talked about that on Wednesday, but if a person's starts with an S, right above the rectum there is a muscle or sigmoid.
The sigmoid colon.
Yeah, so if the sigmoid colon gets damaged or whatever, they can't use that part of them anymore. Mr. Donahue said that they would pull the
Oh, yeah, the
Mhm.
pull.
Yes.
So is that what like the surgical name for that would be? If they have to do a procedure to cause the intestines to come out?
So yes, we could have basically like a man-made surgical fistula.